So this is our the four main complications of cataract surgery cause, which are small pupil, subluxated lenses, decompensated cornea, and hard cataracts. Let's have a look at this first case. This person suffered a blunt trauma from a mango that fell on her eye when she was lying by the swimming pool under a mango tree. So this is what happened. The lens is basically subluxed into the anterior chamber. So you have to do a small rhexis. So only when you have a good rhexis margin can you engage the rhexis with capsule hooks. So do a good hydrodissection, pop it up, and put hooks to stabilize the capsular bag. So once this is done, you can just use, once the bag is well stabilized, you can just use phaco and remove the pieces. You can see that because of the 5 hooks that we have put and not 4, there is more equitable distribution of force, and because of that, that bag doesn't move at all. Bag is absolutely stable. Do a slow and stable IA. And pull the cortex off from the fornix. Once this is done, complete the irrigation aspiration and inject a capsular tension ring. So when you put in the CTR, you make sure to inject it smoothly in one go. Otherwise it might snag the capsule, and this happens many times when the capsular bag rips. So inject it in smoothly, and many a times with generalized zonular weakness, not like a 180 degrees or 270 degrees, just generalized zonular laxity due to trauma, just a capsular tension ring will do the job. In goes the IOL. So I waited to see everything is moving okay. Is the capsular bag stable, or will we have to put in an Emmett segment? Mandatory air at the end of the case to see everything is good, no vitreous in the AC, and case is over. Now my next talk is in a subluxated case.
Should
like
we
this,
use capsule hooks or simply drop anchor when required in the case of a subluxed lens?
So let's have a look at two
We
cases.
use the
When do you use
femtocataract
capsule hooks, and
system
when do you
to
have to
provide
use
a
a device
perfect
like
4
an anchor?
mm capsule or rhexis.
So, hi Arshul.
This gives us a perfect punched out rhexis.
So this is using
Next, we use sodium hyaluronate to create space for us between the capsular fornix and anterior rim of the bag and the cortex sigmoids.
If you do 50 cases like this,
then we can use capsular hooks which differ from traditional iris hooks in having smooth paddles at their ends to spread the forces applied.
With capsular hooks. This is the main
After
advantage
doing
of
an
having a
INA,
femtosecond laser, not to do
we
grade
then
1
pass
or 2
one needle of a
cataracts.
double-arm ninoproline through a capsular ring segment. Railroad this needle out of the eye and then railroad the second needle 3 mm away from the first one, making sure not to nick the capsule. Position this ring segment after railroading the second suture
segment and then put
in the eye. Tension the ring segment by suturing the two ends and follow it up with a 12 mm capsular tension ring to stabilize the bag in its entirety and then inject the lens.
Now what if you have a poor
What do we do if you have a poor rhexis with a small rim of capsule? Here we can see an aborted rhexis with a femtolaser creating disruption under the capsule rather than at the capsular plane. Now it's time for us to make a good rhexis. We use a sharp rhexis forceps, but in this case the rhexis tries to run away. Even though we can pull it back, the capsular rim left behind isn't good enough for a capsular hook. So in this case, what can we do now? So let's mark 3 mm from the limbus.
So now we are stuck with,
and then let's look at the ASIA anchor, a device fashioned after a boat hook
of capsule
with 2 limbs. We retrieve a double-armed ninoproline from supplies and thread one end of the needle through the suturing hole of the ASIA anchor and then tie it tight. Railroad the suture out of the eye and position the anchor to support the capsular bag. After we can do a slow being held by its two trailing legs.
And then engage the capsular bag with the ASIA
Adjust
anchor.
the suture tension.
And
then we have to lock the suture in place by passing this needle twice through half thickness of sclera.
With the needle.
So that's once.
Once you tighten the suture after passing it
twice.
to half thickness of sclera,
then you simply tie it tight. This gives you a good capsular bag with adequate tension,
two rounds in
which will hold an IOL.
It gets buried inside the sclera itself.
Now it is time to inject the IOL gently. If you inject it ham-handedly, you might dislodge the anchor. So we inject it slowly on top of an iris repositor and then dial it carefully into the bag.
Now the lens is well centered.
This gives us the desired result.
And the case is over. So these are the two cases that I wanted to show. Who wants to go next? Harshul. So introducing Harshul, young and dynamic surgeon and the head of Life Beyond Ophthalmology, which I think is as popular as the whole conference itself. Harshul, what are you going to teach us? Yeah. So one of the biggest bugbears is small pupil management, and Harshul is going to speak about it now.
Thank you so much, Dr. Cyres, for your kind words and making me part of your instruction course. So I'll be sharing few videos of management of small pupil with malignant ring, because that is my preferred device to go for whenever we have a situation like this. We all know that small pupil always causes challenge to any phaco surgeon because of the poor visibility of while doing all the steps of the phaco surgery, from capsulorhexis to nuclear fragmentation to each and every step. So if we use these expanded devices, our life becomes much more easier. So this is the malignant ring, which comes in this casing here. So it had original version which used to go through 2.4 millimeter incision, and now we have 2.0 version available. So the classical malignant ring, if you see the 2.0 version, it has increased scroll depth here, so it's easier to engage the pupillary margin, and moreover it's more flexible, made of 6-0 polypropylene as compared to the classical ring which is made of 5-0. So this is the injector in which it's loaded. So you need to pull on this button there, so this ring goes in this tubing and it's ready to implant. So this is the case which has a small pupil, white cataract. So you always try to put a Kugelin's hook through side port so that you can, so the leading scroll, it engages the pupillary margin, and this Kugelin's hook guide the lateral scroll, so that most of the time we are able to engage both the lateral scrolls to the pupillary margin and release the proximal scroll using this Kugelin's hook. And again go ahead and put OVD, and either you can go through side port or main port and engage the scroll. So the biggest advantage is that once this ring goes and it expands the pupil, pupil dilatation is maintained to 6.25 millimeter size. It comes in two sizes, 6.25 and 7. 6.25 is the normal routinely we use, and it's in the pupillary plane, so all the maneuvers are same as in the normal cases. So if you compare it with iris hooks, the iris always tends to tent up towards the incision. It shallows down the anterior chamber, and it causes uneven stretching of the pupillary margin. So another case, this was a case post keratoplasty and white cataract was there. So this is another way of loading and using this Maligne ring. So I'm using it for many years. This is the cartridge of microol incision, microol lenses, which has 1.8 millimeter of the injector system here. So in the same way we load the lens, I put the leading scroll and you see the both lateral scroll get compressed and it's pushed in this tube. And see how nicely the scrolls come out. The leading scroll goes there and the lateral scrolls, they engage pupillary margin, and there was a peripheral iodectomy which was done here. So pupil, many times you need to use bimanual technique. You need to go through side port and stretch the iris margin and push the Maligne ring. So see, once this ring is in place, it makes your life much more simpler. So another advantage is that if you have a adequate pupillary dilatation, you can size your capsular axis very well to the desired size, which is very important for long-term stability and for good effective lens position. If you have a smaller axis, it may cause phimosis and decentration of lens. So to take it out, you need to release all the scrolls one by one, and either you can use the same injector through which you injected it, or you can just use the inverted Kuegelin's hook, go ahead and put OVD and just pull on one of the scroll and use forceps and the entire ring comes out. Then you hydro stitch all the incisions. So here I have just disengaged all the scrolls, and I'll be using the same injector to again take it out. So you need to go ahead and engage with this finger shaped metallic thing which is there, and use Kuegelin's hook from side port to guide both these lateral scrolls to go in the tube. So that when these lateral scrolls go in, you can just pull on the proximal scroll which comes out. So this is another way you can take this ring out. But be careful that you disengage all the scrolls properly from the iris margin. Otherwise you may cause iridodialysis if you are not careful enough. This is another case at very narrow angles and laser PI was done. The same way I'm loading the ring, and see the ring goes, the proximal scroll, lateral scrolls. So here sometimes the third scroll doesn't go in one go, so we need not worry, just rotate the ring and you can engage the third scroll. So it's very flexible ring, it's easy to insert, and you can. So this was a case of IFIS. So now our protocol is whenever patient is on tamsulosin, he has moderately dilated pupil, so the threshold has become very low, we go ahead and put Maligne ring. So this, you'll realize it once I take out this ring. This was a denser cataract, so we take off the entire cataract and see the pupil has come down and iris is floppy here. So it's very useful in cases of IFIS also, that rather than waiting for all the iris and everything to prolapse out, you go ahead and in the first instance you put this ring, which makes your life easier. So I think this Malignant ring is a wonderful device to manage small pupil cases. Thank you very much, Dr. Cyres. Yes. So next, I'd like to invite Dr. Kumar Doctor from Amchi, Mumbai, to present his talk. Yeah.
HDMI.
Is it on? Yeah. Arshul, in which case will you use a Malignant ring like this, and in which case would you prefer to use a Bhattacharjee ring, B hex?
Yeah, hi. So I only use Malignant ring. I have tried BHEX ring, but the only issue is about the pupillary expansion, which I got with the BHEX ring. It's not more than 5.25. It's very thin, and there's a lot of iris chafing which occurs, and I feel that it should be more sturdier to hold back the iris, especially in IFIS.
In very hard cataracts, when you need a large area to operate, then it becomes difficult.
So we all have been using this Malignant ring for, I think, for last decade, and I started using 2.0 version for last 1 year, but again shifted back to the original version, because again the original version is sturdier. It's made of 5-0 polypropylene than the newer version, which is thinner. Moreover, I can reuse the original version 5 to 6 times before it breaks down. So it's become cost effective. Whereas the newer version is thin, it has more scroll width. In 2 or 3 cases, it tends to lose its shape and everything.
Right.
So for me personally, the Malignant ring works better in my hands. Your experience about the pupillary expander?
I still love the Malignant. I have not changed. I tried the BHEX once or twice, but then I slowed down and I went back to the Malignant.
Yeah.
Only thing, when you have to do a femto with a ring, maybe the BHEX is a better option. I'm going to show a case with Malignant in it, because you can put a BHEX through a side port. So you just need to do an MVR, inject BSS, and then put the BHEX, do your femto, and then go ahead and do your case. So maybe that's a better choice for femto cases.
2.0 version you can insert through 2 mm. So does it make difference? 1.22 more?
0.75 and 2 may not make a big difference, but theoretically it's superior because it's just a side port, right? So you're going through that and your chamber is really not collapsing. When it comes to femto, in such cases, we have to form the chamber. I had made once a mistake, my first case. I nicely put the Malignant ring, and then I put Helon GV like an idiot on the anterior capsule. So what happened was the anterior capsule flattened down. Now the femto got confused because it lost its curvature and it would keep searching for the anterior capsule. So that was my learning curve. And another thing that happens is, if you have any viscoelastic and you use femto energy, then it gets absorbed by the viscoelastic. So now the rule is a very small incision, which I'll show, and then put your Helon GV only along the inner lip of your incision. So that's self-sealing. Your anterior chamber is filled with BSS. And then you do your femto and nothing happens. So this is one lesson I learned the hard way, but I realized this, and now that's taken. That's why I thought that if you have to do a femto, then maybe a BX is a better.
But people are using Malignant ring with femto.
I'm sure. So it's not that I'm not using.
Because anyway you are saying, because I don't do femto, you are saying that you need to take off the viscoelastic. So in both the cases, you will take it off, and 1.2 mm side port or 1 mm and 2 mm they'll seal nicely. Because
it is self-sealing, so that's not an issue. So this is what I was talking about. This is flax in a small pupil and a hard cataract, but it's not as simple as that. So a small pupil, yes, as I mentioned, you have to use BSS in the anterior chamber, remove the viscoelastic. Do you need to take a suture or not? I don't take a suture, okay? And the ring is on the pupil, but then the viscoelastic has to be removed from the anterior chamber. You can't leave the viscoelastic in the anterior chamber. If this is a small pupil, we have different causes or problems. One is the AC will flatten out in case you don't have it, but the challenge is in energy setting. So if you leave any viscoelastic in the anterior chamber, you may need to increase your energy in the femto, and a suture is really not necessary. So coming to how this case was, I always say, this was what I found when I was driving in the US. Staying in bed and screaming, "Oh God," does not mean you're going to church. So you have to know whatever you're doing. So this is a case I wanted to present. It's quite a challenging case. I'll tell you what all it went through. It's a small pupil, irregular shallow anterior chamber, angle closure attack of glaucoma, peripheral iridectomy done, patient has prostate, patient has a hard cataract, and patient needs a femto. And one more thing, patient has a subluxation. So now the complexity begins, and patient wishes to have a femto. So this is the case. You can see the irregular anterior chamber, you can see a peripheral iridectomy, you can see a sphincter atrophy because of the angle closure attack of glaucoma, and you can see the subluxation. So this is all that the pupil dilates. The pupil doesn't dilate more than this. And you can see the subluxation, and you can see the peripheral iridectomy. And now this is not as soft as you think it is. This cataract is quite hard and quite dense. So this was what to do now. So question here is, we started with the procedure. Yes, we have a video on as image guided procedure. We go ahead and make our main incision. Once the main incision is made, we put in a viscoelastic. So you can see that we're making the main incision in the axis as planned, put in the viscoelastic. And here I'm going ahead and putting the Malugan ring. So to put the Malugan ring as shown by Dr. Harshul is now quite easy. The plunger is just going in. You have to scroll one end of the loop into the iris, and you can do it as a one-step procedure. So you need to tilt your hand a little bit to the left, a little bit to the right, get the iris into the loop, and you are done. So in one shot, you're getting 3 loops into the iris. You can even do the 4th one at one shot. I use a Krugner's hook. That's the right instrument. Don't use a Sinskey hook. Don't use anything else. If you use a Sinskey hook, sometimes it slips and the whole scroll will go behind the iris. So here, whatever I used, I'm not sure, but I'm using something from the superior incision, and then making sure that I go ahead and engage the iris. So this is the Krugner's hook. Go ahead through the side port to engage the sub-incisional iris. This will never ever slip. If you use a Sinskey hook, it can still slip and it can still fall behind. So now I got an adequate pupil. You still think it's a soft cataract. It is not. So it's an illusion that you're getting. Now the next step is to remove the viscoelastic, okay, from the anterior chamber. And as I mentioned, a little bit of Elon-GV along the inner lip of the incision, because this incision is 2.2. And then as you see that I have done the femtorexis, I've also done the 4-segment or 8-segment division. Here I've also done that. You can see the 8-segment division. But I'll just tell you what happened on the femto. So you can see here, this is the femto bit of it. So you can see the Malugan ring in place, 1. You can see the distance between the iris in both the different areas. So that shows that this lens is subluxated. And you can also see that bowing down of this part of the lens. So this is a subluxated cataract, a hard cataract, Malugan ring in place. And then I'm going ahead and doing the rexis. 8-segment fragmentation is also quite possible here. So 1.2 millimeter rexis, 8-segment fragmentation, and we are all sorted. So this is all in place, right? So now let's go back to the case. I've started, the rexis is removed, and I've started phacoemulsification. So you can see the same ring is in place. Now notice 2-3 things. The whole nucleus shakes, obviously, because there's no counterbalance, there's no counter traction, there is no support, and there is a subluxation. So 2-3 take-home messages from this whole video you will get. I'm trying to rotate the nucleus. I'm not able to rotate this nucleus, the main reason being subluxation, right? So I'm not supporting the bag. This is not the right thing to do. Always support the bag before you start grooving. That was one thing. I realized over time that yes, this is not the right thing to do. So next time, of course, I will be putting in the hooks much earlier. So I go ahead, I realize that I'm trying to rotate it bimanually. It's still not happening. So then ultimately I could get a little bit of bimanual rotation of the nucleus. Now I go ahead and put, unfortunately that day I must have not had capsular hooks. I'm using iris hooks. Now this is not the right thing to do, friends. Definitely you should use capsular hooks. From that day I've started keeping almost 2 of iris hooks and 2 of capsular hooks in the OT. So always it is there as a standby, and there's never an issue. So now as you notice, moment I supported the capsular bag a little bit, the rotation became much easier. So go ahead and do your phacoemulsification. Doing that. and then removing the nucleus one by one, one by one, one by one. Now, as soon as I was doing this part of the nucleus disassembly and removal, I realized that even superonasal, where my chopper is, the bag is little weak. So now I have the Mulligan ring in place, I have one iris hook in place, but I'm still not happy with the support that the bag is getting. So then I decided that yes, I need to go ahead and put one more hook there. So this is the epinucleus, the main nucleus is out, but I decided that yes, this area the bag needs support. So I go ahead and put one more hook there and support the bag. And then I remove the epinucleus, etc. So now this is all good. This will be followed by bimanual IA. We know that there is a subluxation. So this has to be then supported with an endocapsular ring. Now, as far as the trick of inserting an endocapsular ring is, always start placing the endocapsular ring in the direction opposite to the area of subluxation. So if the subluxation is here, do not start putting the endocapsular ring from here, because if you do that, your two eyelets will come in the same area of the subluxation. So always start putting the subluxation the endocapsular ring in the area opposite to the subluxation. It's a very simple trick that you take home. And once this is done, I'm just doing a bimanual IA, which a little lower bottle height. So now you can see that the bag is held well, okay, and everything is going fine. And now, as I mentioned, I'm putting the endocapsular ring in the area opposite to that of the subluxation. So if you had capsular hooks here instead of iris hooks, one more thing we have to remember, that the capsular hooks have to be made a little loose before we put the endocapsular ring. If that's not done, again there will be entanglement there at that level. Luckily I had iris hooks, it's not reaching the equator of the lens at all, so that is quite safe. But if I had capsular hooks, I normally loosen them a little bit and then I put the endocapsular hook. There are two types of capsular hooks. These capsular hooks which I use are made by Madhu, no financial interest. They don't have a large area of hook in the periphery, but some of the capsular hooks which cover a larger area of the equator have a loop, and that's where you have to be even more careful. So the endocapsular ring goes in place. I have the Mulligan ring in place. I have two hooks in place. And then I'm going to put an IOL in the same area of subluxation. So I'm going to further support this area of subluxation there. So this is very simple. And then just release it inside. And just rotate your hook and it goes in. So this whole area of subluxation is well supported. Put in a single piece IOL into the bag. The haptic further supports your area of subluxation. And then that is followed by removal of the hooks and removal of the Mulligan ring. At one stage I thought I did get a vitreous strand there, so I think I did a little bit of vitrectomy and then made sure that there is nothing there, and it was all done. So you can still see that PI, and this was a subluxated case. So thank you all for your attention.
Thanks, Kumar. Next, I'd like to invite Dr. Gaurav Luthra from Dehradun, and Gaurav is very, very well.
So at the outset, I would like to thank Dr. Cyres for including me in his course, and for those of you who don't know, what Cyres has achieved in the last year or two is something great. So going on, this was a patient who was post vitrectomy, and challenging one because it was totally subluxated and there was a lot of phacodonesis. Fellow eye was lost to previous multiple retina surgeries almost 10 years back. So this was the only eye of the patient, and he went from 618 to 3/60 and then decided to get operated. It turned a brown cataract in this time, and being a vitrectomized eye, we were anticipating all the issues that you can. So and had significant astigmatism, so my threshold for using toric lenses is low. Nothing wrong in doing the toric lens if the bag was intact, so we decided to go with a planned toric IOL, except that the capsule was very friable. We could do the rhexis. I would have liked a bigger rhexis, but we could just about get a 5mm smaller, about a 4mm rhexis, because we didn't want to kind of take a lot of risk with the bag which was moving around so much. It was obviously a very, very hard cataract, but even with a small rhexis, staying in the central A zone, we could manage with gradually getting everything out. and of course using the capsular hooks for stabilizing the bag because the bag was quite mobile, and being a one-eyed patient, we didn't want to take any risks whatsoever. So at the end of this process, we were left with a bag which was very friable, had lots of plaques, and I'm sorry, what happened to that? Had lots of plaques, and we set about trying to, get those plaques out. And obviously, since they were nicely stuck doing the cortex extraction, we had to keep trying to polish it and peel those plaques, and it was a little tough because you could increase the dehiscence at any point, you could break the PC. It was an eye which had previously held silicone oil, so the capsule was very peculiar as well. So painstakingly, and this is all edited, so painstakingly we managed to clear one quadrant, and then I realized that I have to change tack, and I went in. So these are special bimanual handpieces that I'm using. These are both sandblasted, and they are matched to my incision. So I decided that I'll go with a technique which I call as the jet polish. So for this you need to go from the main port because it doesn't work from the side ports. You go in from the main port, keep the posterior lip depressed. So that sets up a very high flow system. And using the irrigation handpiece, you can go and do a jet wash, which basically sets up a very fast fluid. And then here we've changed hands. So initially I did that one quadrant where it was possible to do it from the main port. Now since I have to do it on the other side and I want to switch hands, so what I'm doing is I'm running now the infusion from the side port, but I'm opening the main port with another instrument so that it still sets up a high flow process. And now I'm going and doing the same thing in all the 360-degree areas of the equator of the bag, loosening up everything, because then it'll make it very easy for me to aspirate. Now just watch how I aspirate. I was struggling to clear that up initially, and now everything is so nicely loosened up. I call this as the jet polish or the jet wash, and it works extremely well to clear up all these resistant plaques and all that sticks to the bag and very sticky cortex or stuff which is not ready to go, except for plaques like the one which is right in the center, which requires to be peeled. So now this plaque, my only hope is to peel it or maybe do a small rexis in the center because can't leave it there. So I try to take it off very gently, and then changing hands and changing forces, making sure that, because this capsule, as we all understand, is very, very friable and easily breaks. So you have to ensure that neither are you putting in a lot of viscoelastic nor less. You don't want any kind of damage to the capsule there. So we managed to, by pulling in several different directions, and since all this is edited, so you can understand that would have been more painstaking than what is evident here. And finally I was able to get it off, and I was very happy that now I'll have a great outcome. I'll go ahead, put in a toric lens, and now I was a bit relaxed. So it's almost like paradise regained. But you can see that the rexis is really small, and now for a moment I think, oh god, sorry, that was a nightmare. I thought all the cortex came back. So so now that little bit left, and see what I've done. I've broken the rexis there. So let me just take you back. What I was trying to do was, I was just lazy. I was using my right hand and thinking that I can get that cortex out. Went a little too far, and after all that effort, I managed to break the rexis with my cortex removal. With my bimanual. So anyway, now I'm in a situation, because now it'll be tough to put in a toric IOL and let it remain well centered. So I changed the lens. I now go in with a regular single piece lens, which will hopefully remain in the bag. And we ended up managing this case fairly well. Patient did well. The astigmatism was about 2 diopters, so it was not so bad. But eventually, the lessons were all learnt. The cortex that can be removed like that, what I showed you, and then of course not being lazy. And this is my favorite trypan blue test for any leaks, and that helps me check for any micro leaks and all. And so this was one new way of using these devices. So now this is another case where a patient came with trauma to our hospital and was operated by a cornea surgeon for a perforation, and went on to develop a traumatic cataract. This was the perforation repair which was done, and there was, after that, Patient went on to develop over a period of time significant traumatic cataract, a rosette cataract, also would require surgery, and the problem was the big iris defect. So we had to manage this as well. We thought of doing single pass 4-throw pupilloplasty kind of a thing, but frankly there was almost no iris tissue here, almost 2.5 clock hours missing, and even this was not enough for me to fashion a pupil, and the defect size was so huge. So we started about looking for prosthesis which could something which could block this area. Patient was symptomatic with all the glare and everything. So while doing the cataract, we also noticed significant astigmatism, so we decided to correct it with a toric IOL, and it was symmetric bow tie. So we went about several designs and finally settled with a design which was, in fact this was one of the prototypes which was supplied to us earlier. We also got one which was about 2/3 of this. So we finally settled with something which was about 2/3. We got this kind of lesser than this, because this would have been very difficult to insert as well and manipulate inside. So finally went with this, and the cataract surgery was mostly straightforward. Not much to the cataract surgery, and once the cataract was out, we could then put in a toric IOL, position it, and then the process of seeing. So I think, okay, so we went with the same ring, and that's why that one is shown there. I'd forgotten. We had got 3-4 designs made. In fact, we had kept aniridia rings as well, which come in pairs, because we were not sure that this is going to stay. So after 3 or 4 trials, and this is the final trial where we managed to, we also thought whether we should be putting this in the bag, but there was no way it was going to go into the bag. It was very bulky. So this had to be positioned in the sulcus, and because there were some iris issues here, we finally managed to get it behind the iris. But cosmetically, it came out really good. Patient did really well subsequently. And this is how, so this is the segment which is kind of covering everything, and this is the toric alignment, and the optic edge is nicely covered. So patient went on to do well, and the astigmatism correction came out so beautifully that patient was 6'9" unaided, and there was almost no residual astigmatism, and eventually accepted about this much and did well. So this was one case. If I have time, Cyrus, can I show one?
Yeah, go ahead.
Okay. So this was customized with Care Group, and they worked very hard. They were quite supportive because they gave 3-4 designs. The only thing is that I want to see long term, this is about a year old, how long the pigment lasts. That's probably the only issue which everybody thinks may or may not work. But I do have several patients with the aniridia ring, which also from Care Group, almost more than 15 years old. They somehow have still held their pigment. So, and I have no financial interest with them, but they are supportive in these areas. So a BHEX, I don't know, has somebody shown a BHEX yet, Cyrus?
No.
So I thought, because I removed my Malugin slides, although my favorite is also the Malugins, but I thought I have to do justice to BHEX as well. It works very well in certain situations if the pupil is not very small, very rigid. Otherwise, you'll have to do a stretch. It's a very nimble, nice ring. Only thing is you have to learn how to kind of ensure that it goes in. Yes, it is difficult and challenging in certain situations where the pupil is very small or too tight. Then, it becomes a challenge to insert it and even to remove it sometimes. Removing it from the pupil is sometimes a challenge. Removing it from the eye is very, very straightforward. You just have to hold it and it pull out and it comes out. So what Suven actually tells us that to use the forceps, and I agree with him totally now. This is one of the slightly older videos. But today I would also use the forceps which come with the BHEX. That makes it much easier because you just have to go from 3 areas and then hold it from one of the central eyelids and then push it under the iris at 3 points. It holds quite well. The only thing is that you don't get a huge pupil size. I mean, with the Malugins, which I find much easier to use and slightly more challenging to remove from the eye, you can get maybe a slightly bigger pupil size than what you get with the BHEX. So all the same, the price is almost 1/8 or I don't know 1/5, but it works well, and you can then complete your surgery. Bringing it out, as I said, is quite straightforward. If you're not careful, sometimes the BHEX will dislodge and go behind the iris. Then it becomes a little bit of a challenge. But otherwise, if you are careful enough to remove it gently and make sure that it remains anterior to the iris, And very rarely you can see how it catches onto the iris as well and shreds it. So then bringing it out is fairly straightforward, and you can see that it comes out and very nicely from even a side port. So let me finish by showing you a disaster from the Malugins ring, which one of my friends shared with me for my course, which is the Lord of the Rings in the SCRS. And this gentleman is practicing in the UK, and he is also a fan of the Malugins ring. He was after finishing off with the surgery, he decided to remove the Malugins, and as you can see, as he's trying, it's a very atrophic kind of iris. Harshul, this is for you. So very atrophic iris. He is trying to dislodge the Malugins ring, and it's tending to, sometimes it tends to trap the iris tissue, and especially it can get wrangled on it, and 99% of the times it doesn't matter. But now he's got 3 rings off, the 3 twirls off, and then he decides that he got the 4th one. He manages to now use the injector to remove this. And now you can use this injector to go from a 2 millimeter incision, and that's the good thing about it. So you have to just go from the side port and catch it. So in this department, I think the BX is much simpler. You just have to hold it and pull it out. But once you get used to using this, it also works. And Harshul uses a very nice...
you just use the inverted Kugeln
yes,
stroke. Yeah,
yes.
most of the time I use that.
No, even to inject you use that cartridge, right?
Yeah,
so
yeah.
Now once you catch on to it, which can, as I said, can be tedious, and I'm hoping this video moves forward faster. Maybe this is not the edited version which I thought I'm showing, but anyway.
Slow motion,
yeah, I don't know.
Slow
it
motion
seems to have got
fake.
stuck there for some reason. Anyway, he catches it finally. Then, of course, as we all know, how sometimes it will just get entangled. Then you just push it back, and see, now he's made a mistake.
Yeah, it was.
Yeah, so that's why I'm showing this, because if you make that mistake, then this is what you have to deal with. Now, with that mistake, it has twisted and it has caught the iris. That's what I remember. Now it's caught the iris, and now it's going to...
Because his attention is only
on the thing,
on that
right?
nozzle,
So these things you have to be careful about, and see, now it's a total mess. So anyway, so finally I think he was able to free it, but not before traumatizing the iris completely. And so I think all the devices are great if you know how to use them and know how not to make complications with them. And but in general, I think the Malugins is one of the safest expander devices that I've used as well. So I'll stop here.
I want to ask, that first case, there was like a subluxation.
Mm-hmm.
There was like a overall generalized ulnar weakness. Now your Rexis tour, you use 3 capsular hooks and you put a lens in the bag. So wouldn't you think that bag would need support?
So, there was Donesis, all right. It was a vitrectomized eye, so there was no vitreous support as well. But, the other option was to have just removed the bag and gone with a glue dial or something, right? But I felt that there was enough support at that time. I had planned to put in a CTR, but because now my Rexis was broken, so a CTR was not going to be possible. So then I just decided to go with that thing, because I had meticulously cleaned the capsule and didn't want to feel like sacrificing it. But yes, if I think about the future, I should have probably put in a 3-piece lens, number one, because I could then later on use that to, you can use it to kind of anchor it to the sclera if you need to. And only problem is that by this time, at the end of surgery, my thought process was probably, after you work so hard and you clean up everything. But in retrospect, I think I should have put in a 3-piece. That would have been the wiser thing to do, rather than put a single-piece lens, or even take away the bag and do a glue dial kind of a thing.
So if this happens and your Rexis is torn, has anybody put an endocapsule ring after this?
So some people have shown it, but I personally don't like to do it, because it can extend. See, either use a smaller ring, which doesn't work, which has no meaning. If you put an adequately sized ring, it's supposed to stretch the equator of the bag, and if it is doing that, it will just extend the break in the Rexis, and it will just kind of go behind possibly. And you might even have a ring which is which drops. So I don't see any point in putting a ring once you have a broken rhexis of this kind.
All right. Thanks very much, Gaurav. Since you are the leader of the hooks and rings, I thought that you could really do justice to this topic. Next, we call Professor Keiki Mehta, the pioneer of lens implant and phacosurgery in India, to teach us about, I think it's femto and hard cataracts. So the question is now, everybody wants to buy a femto laser, everyone wants access to it. Is it really a useful tool, or is it just an expensive toy to attract patients? So let's see what Sir has to say about it.
वीडियो कर दो ना पहले, उसके ऊपर नीचे नीचे बस बस पर बराबर बस. It's a short little video, but it's an interesting little one. It shows how you can handle a subluxated lens with the femto cataract comparatively easily. Problem with all subluxated cataracts are fourfold. You stabilize the subluxated lens, how to do a rhexis, you phaco the residual nucleus, and you finally stabilize the IOL bag. Femto is extremely helpful, most important reason being that it gives you a perfect rhexis. It fragments the nucleus to enable slow motion phaco. Sorry, कुछ भी नहीं आया था पहले से करा. All right. Okay. So as I said, the problem is fourfold: to stabilize rhexis, phaco, and finally stabilize the IOL within the bag. And femto cataract is very useful purely because it gives you a perfect rhexis. It fragments the nucleus to enable slow motion phaco, and all this with no stress on the zonules. But you have to manually configure. That is one of the big problems. So let me show you how it works. Essentially, you set your data onto the phaco. This is the person with the lens. I'm just going to show it to you in a few moments so you know how it works really. And as you can see here, you notice the lens is completely subluxated downwards. So now the only problem is with this level of subluxation, you have to now set the femto to match it. If you can't match it, then it doesn't work that way. So you set it on both sides as well as the edges, because in case you don't set it properly in the edge, it tends to tear the edge. Once you have done that, then there's really not much of a hassle. Then the posterior capsule. In this case, as you noticed, because it is subluxated, the posterior capsule is all bent downwards. Once this is done, then the lens can be seen properly set, and we now have to set the iris plane on which it is going to set so that it can have its judgment. You center the rhexis now onto where you want it to, and then you proceed. I normally just do a simple cross-hatching, which works fine, well enough. The laser works very fast. There's only a few basically a few seconds, normally about 4 to 5 seconds before the rhexis is completed. One of the reasons I'm cross-hatching it rather than doing lines is purely because it is easier to aspirate these lenses out if you cross-hatch them. Though I know that most people prefer just to use 4 lines and that is it. So once this is done, we take the patient off and transfer him onto the other side where you can now see the thing. Now as you noticed, the lens was very much subluxated. So the important thing is before we do anything else is to first fixate the lens. If we don't fixate the lens and the bag and everything will go on to the retina, which makes your retina surgeon very happy. Having done that, the next step is you've already done your rhexis. So that's not really a problem. Having done the rhexis, you just separate the rhexis a little off. Notice the rhexis floating free. And then use your hooks to anchor them on. Because it's a loose bag, using capsular hooks literally pushes the bag to one side. So I prefer to usually, in these sort of cases, to use just regular hooks. So we put 4 hooks and that stabilizes the bag. And once the bag is stabilized, then the next step is of course to feed in a Sione ring, a capsular tension ring, CTR, which you feed in before you try playing any tricks with the lens. Because the first thing which you require is to stabilize the bag. Once you've done that, then you can aspirate out the lens easily. And the easy way of handling it is simply to push in the ring on one side, usually from the opposite direction from the area where the main rhexis is. Let it fall back into place. And then inject your lens on top of it. One of the easiest lenses to use in this case is a Rayner, because it is sufficiently rigid to hold the bag in place and at the same time is friendly enough to remain there. And now that's as simple as that. Just a plug for iAdvance next year, though the dates may need to be changed since All India has changed its dates just recently.
So final talk for today is a very young and talented surgeon from Mumbai, not so young anymore, but very talented nonetheless. And he is a great corneal surgeon. So remember that all of us as cataract surgeons, sometime or the other, we are going to have endothelial difficulties and Fuchs dystrophy and corneal edema post-op. And how should we handle this? How do we do DSEC ourselves? So DSEC for the cataract surgeon is the topic I gave him. And I also do DSEC myself, which I also learned from Rajesh Fogla and by watching Jatin. So I thought Jatin can share some very important and helpful tips how an average cataract surgeon like me can do a DSEC surgery himself without having to send the patient to LV Prasad or to the corneal person down the road.
Thanks, Cyrus. Thanks for calling me not so young. And you're not an average cataract surgeon, an excellent cataract surgeon. So just the layout be, why should we really learn DSEC as a cataract surgeon? What are the instruments that we would need to have? Simple steps in terms of tissue preparation, insertion of graft, and managing the graft in the eye, and post-operative regimen. So on table, a lot of times we see patients may have a large descemet detachment, or sometimes the descemet is just eaten by a phacoprobe inadvertently. Patients may have Fuchs dystrophy, or your own patients may be having a PBK. And it's not always possible to call a friend to do the procedure when it's quite simple to perform. Well, instruments are nothing very special. All you need is your cataract set. Tissue preparation does require an artificial anterior chamber, which is easily available with Epsilon. You need a reverse Sinskey hook, your cohesive viscoelastic, a sheet glide or a Busen glide. These are all simple instruments which most of us usually have, or we can prepare them using our own cataract set. So the surgical technique is quite simple. The first step is to prepare your donor tissue. Second is to decide how would you do your surgery in terms of site of incision, your anterior chamber maintenance, Desmet stripping, donor insertion, air management, and securing the wounds. So tissue preparation starts with selecting a proper tissue. Usually any donor which we will get from the eye bank having a donor cell count of more than 2200 cells is good enough. And scleral rim should be adequate in terms of the shortest diameter should be around more than 15 millimeter size. Well, today we are really lucky that eye banks do prepare us dissect tissues and provide us. However, in case we don't have an access to a pre-cut tissue, we can still dissect them manually. And even that does not require any special instrumentation. So all we can do is just mount it on an artificial anterior chamber, pressurize it properly, make a 400 micron groove, and you can use your crescent blade to go and do a dissection, just similar to the way you would do for an SICS. However, the trick is once you reach nearly around half of your area, you would see that it's difficult to now proceed to the other half of the cornea. So in which case what you can do is you can just cut across using your corneal scissors. You can increase the wound size, you can just cut across the wound, so that now you have an easy access to reach to the other side of the cornea to complete your dissection 360 degrees. So you don't require any special dissectors. A simple crescent knife by itself can help you to complete a 360 degree dissection of your donor cornea, which you can now use for the dissect surgery. So the tip is, do not proceed unless your anterior chamber is pressurized, the artificial anterior chamber, because if it's not properly pressurized, you may end up having a anterior perforation or a posterior perforation of a donor tissue. Use a tissue with a good size of the rim. If you think the clarity is not good enough, you can remove the epithelium. And after you have dissected, you can even mark on the stromal site so that you know the orientation after you've inserted the graft inside. Now moving to the site of the incision, you can usually try to use the same incision as you are using for your cataract surgery. If you're a beginner, you can initially use a scleral incision because that's easier, because you can make a little bigger incision around 5 to 6 millimeter in size. And if you are having a patient who has got a filtering bleb, you can use a temporal one. Remember, the internal lip, which is posterior to the graft-host junction, can be used for failed graft. Again, the size of the incision can either be 3 millimeters or 5 millimeters. It's preferred to use a 5 millimeter when you are a beginner, so that you compress the tissue lesser and in turn have lesser endothelial cell loss while you're doing the insertion. Initially, people would prefer doing a taco fold, a 60-40 fold. However, it's seen that the endothelial cell loss while doing this fold is much higher compared to now using simpler techniques like your sheet glide or just pushing the tissue inside the anterior chamber by placing it on a cohesive viscoelastic. So a simpler technique like using a 5 millimeter incision, and you can usually just pull it through. You see that the endothelial cell loss is much lower in those cases. So again, for beginners, have an adequate size of your incision. Smaller incisions lead to more compression of the tissue. And if you're having a scleral incision, try to have a good hemostasis before you try to insert the tissue inside the eye. Or else if you don't have a hemostasis, the whole anterior chamber will be filled with blood. It will be very difficult for you to manipulate the tissue inside when the blood is there. Again, Desmet stripping is an important thing. When you're trying to strip, just see to it that you have adequately stripped the Desmet membrane. So a reverse Sensky hook is what is preferred. Don't try to go very hard because you don't want to pull on the stromal fibers, because if you're doing that, you'll lead to more scarring of the tissue in the stroma. And if it's a simple case of PBK, you don't even need to strip the Desmet membrane. Only a diseased Desmet membrane, like in case of Fuchs dystrophy, needs to be stripped out. For a PBK, you can just do a non-stripping endothelial keratoplasty, which is just good enough. So if you are not able to visualize your Desmet membrane properly, you can use a forceps, a chandelier illumination, or a trypan blue light. All of these can help you visualize the Desmet membrane easily and help you strip it out of the cornea. Or also you can fill the anterior chamber with air, which gives a good contrast, and then you can do an air desmetorexis. Again, like if the diseased Desmet is not diseased, like it's not a case of Fuchs dystrophy, you can just do a non-Desmet stripping endothelial keratoplasty and they give just equally good results, and there is no increased haste in the interface whether you score or don't score the Desmet membrane. Again, For beginners, they can use Heal-On in the anterior chamber so that it's easier for them to strip the descendant membrane and ensure a complete removal of your Heal-On after stripping the descendant membrane. Donor insertion, easiest technique is to use a sheet glide. Place a viscoelastic, cohesive viscoelastic on that, and you can use your bent 26 gauge needle or a Sinskey hook to just push your endothelium, the graft into the anterior chamber. And it's always going to be the correct orientation of your graft because you're placing it properly into the anterior chamber, and there is no question of it opening the reverse side down. And it's one of the easiest techniques which anybody can follow. Any cataract surgeon who's well versed with inserting an IOL can insert Descemet's the descent lenticule into the anterior chamber with the right side always down. That's the endothelial side down. And with the glide, you can see that endothelial cell loss is quite minimal, and it gives good results as well. So again, choose one method, master that by keeping on repeatedly doing the same method. Air tamponade, in the initial cases, try to have a complete air tamponade, maintain it for a longer time, and at the end of it, you can just burp a little bit of air to prevent pupillary block, so that you don't have a patient's IOP doesn't increase. Again, it's important that while doing the air injection, you just go below the lenticule. Otherwise, if you may land up having an air above the lenticule, which may be difficult sometimes to remove, and you also be very gentle. Otherwise, you may just land up dislocating the lenticule. Even sometimes the lenticule may just come out of the eye. And don't try to overfill the eye, because otherwise sometimes you see subconjunctival air migration also. So have a complete air fill, partial removal of air. At the end of the surgery, you can put the dilating drop to prevent pupillary block in these patients. Thank you very much.
Thanks, Jatin. And with that, we end the course, and now we have to wait for the next one I'm back here in next 5 minutes.